Thank you very much, Jennifer. I think just for the sake of time, I'll get started. My name is Ahsan Naseem. I'm a psychiatrist at Bryan Hospital, and I've been here for about 6 years. And prior to this, I was at the VA for about 17 years. I'll be talking to you about the focus on mental health issues in the Asian American community in the United States. I think one of the important issues to just broach right away is the fact that mental health is heavily influenced by socio-political stresses. And these days, particularly since the pandemic, the Asian American community has felt the impact of that, and how that affects mental health consequences are important for us to understand, apart from all the challenges which members of the Asian American community have to contend with related to their migration, as well as to the impact of access to care and the completion or completeness of that care. To begin with, our issue of where things are in the present climate is associated with a sense of rejection that a lot of Asian Americans have had to experience, and this is unfortunate. But it is, again, something which we have to recognize as not being just a new phenomenon. Unfortunately, it dates back centuries. And overt aggression against the Chinese is something which led to public lynchings in Los Angeles in the 1870s. The incarceration of Japanese during World War II in internment camps is a well-known part of American history, as is the demonization of Asians during the McCarthy era, the aftermath of the Gulf War, and post 9/11 environment. All had direct bearings on Asians, hate crimes, and impact on their mental health. There is data to support what I'm sharing with you right now. 1 in 6 Asian Americans has experienced persecution, and more than 900% increase in hate speech has been noted against Asian Americans on Twitter. This was just in 2021. However, as we have heard a few times now, this is a community and a population which is growing exponentially. It has grown by 100% every decade, and it, in the last 3 decades, has grown to a rather impressive number when you look at the comparison of the past. Also, when you look at Asian population globally, it actually encompasses more than 50% of the population. However, we are hardly a homogeneous group. There are many different people from very different parts of the world who comprise the Asian American community. And according to some data, there are 28 distinct groups with their own languages, traditions, culture, and immigration history. So the hope is that conversations like today's would lead to more awareness about the challenges that Asian Americans live with, the histories that they bring with them, and also what can be done from a clinical standpoint of improving their chances of success as far as psychiatric care is concerned. So part of the migration is related to losing our support systems back home. This acculturation involves us moving to a new place, having to adopt a way of life, which are the new norms. However, they might conflict with our norms, as in an immigrant's norms. So the way of life back home might not have relevance in the way of life in America, which on the one hand is in need of significant adjustment, but on the other hand can lead to dynamics within the family, particularly for children who are being born here and who know this way of life much more than the immigrant parents. The communication mode of what is common in Asian families is driven by respect, age differentials being given a high priority in our communication. So when an elder speaks, how do you address them, and when do you respond back? To what extent do you challenge them? Compared to the directness of what is sometimes rather appreciated in other cultures, in which if you are not saying something correctly, then, well, you need to be corrected. and age becomes irrelevant. Bullying and anti-Asian sentiment is something which is a reality that Asian American community lives with and has to learn to survive with. Based on history, this is not going anywhere. And it's a blessing that the pandemic is, less of a threat than it was the last 2 years. However, the seeds which have been planted will continue to germinate, and they can show themselves in various financial or socio-political environments again. And this is relevant with an approaching election and how that might impact, again, the rhetoric and the targeting of specific minorities. Psychiatric care access actually is influenced by all of these variables. So on the one hand, there are variables that the immigrants will bring with them. These are cultural barriers which involve things in which a community member might simply not accept the fact that they have a mental illness or they are suffering from psychiatric symptoms. So acceptance of, say, panic attacks, acceptance of post-traumatic stress disorder symptomatology will be very difficult for some individuals, let alone acceptance of psychosis in your family members. There is a lot of reliance on self and within the family and then within the community, which is very successful back in Asian communities in Asian countries. It is a support system which has been tested over the course of centuries now, and it has worked very well. However, this self-reliance can become a barrier to care because the mindset is that, well, we should be able to manage this ourselves. If our son is depressed, we should be able to help him, or he should be able to simply work through this by using willpower or his own healthy distractions. Sometimes patients are even chastised for not putting in more effort into getting better. The concept of the good patient was just referred to. This is the ideal patient that really does not share a lot of their concerns because they are sometimes just so thankful that they have been given access to care. And then providers are so focused on their physical complaints that a lot of psychiatric complaints are not even broached. So many screening questions which are commonly asked are sometimes disregarded because there is the language barrier, and how far can you ask someone about, say, sexual trauma in a way which is not difficult for either side. And the focus remains then on the stomach pain or the muscle aches. Hence, the patient is not really fully evaluated. And unfortunately, a lot of patients do not have the confidence of being able to speak up, especially when they are new to this country, and ask for help for specific things where they need help. Stigmatization of illness within the family, within the community are well known, I think, to all of us by now. Of being chastised as somehow being weaker is common back home. It sometimes carries over to this culture as well and to the life in the United States. However, stigmatization of mental health is very common with people who are born and raised in the United States as well. So it's not just a cultural thing. However, it is playing a significant role as a barrier to getting mental health care. Delay in care access is a result of, again, all these variables put together. Patients choosing to not seek out help because they are doing their best to manage it on their own with the help of their family or other individuals. We had a bit more room. The misperceptions in the medical community are that Asian Americans will usually present with somatic complaints. They will have depression, but they will complain more about abdominal ache. This is not exactly true and has almost never been true. So if you were to look at where this comes from, it actually comes from the medical community not paying enough attention of enough screenings and enough direct questions related to a person's emotional struggles, and relying heavily on somatic symptoms, which are easier by comparison, language-wise and examination-wise, to facilitate in a prompt clinical encounter, and unfortunately ignoring a lot of very important issues. And the result is this misperceived notion that Asian Americans present with somatic complaints. This is a significant mistake on our part. Reluctance to accept psychiatric care is another similar mistake. Actually, Asian Americans are very receptive to seeking psychotherapy. The problem is that very little of that conversation, again, is happening at frequent enough intervals. We need to generate that more. And we can help that happen by educating them on issues related to mental health and what psychotherapy provides. Genetics and metabolism are a specific topic. I can give you a quick example of isoenzymes in the liver. These are responsible for metabolizing a lot of the medicines which are used in psychiatry. And they are usually in smaller numbers in Asian American populations. So the metabolism of medications is actually slower, which leads to the need for smaller dosages, usually, at least to start. But without us knowing about this, we can just use the same dosage for everybody and anyone. And the result is higher exposure to side effects potentially, and higher likelihood of non-compliance because a patient could simply choose not to accept the treatment. So here are some effective care strategies which can be utilized. There is, first of all, emphasis on a detailed history, screening questions to compensate for cultural barriers. Detailed histories require time, and they require the provider to pay attention to who they are trying to communicate with. And as was said, if an interpreter is needed, then an interpreter needs to be utilized. Cutting an interview short because there is a language barrier is a huge disservice. But the depth of that historical detail can help us much more than almost anything else, because that is the backbone of a strong clinical assessment. Explanation of diagnosis and care plans will help a patient understand better and hopefully be more compliant. When they realize that we can normalize, a care plan, that it has nothing to do with any sense of weakness or dangerousness, but on the contrary, more a sense of comfort being provided by the practitioner and ease of accessing this care, of making it something which is not a strain on the provider or on the clinic, but actually something which the patient deserves and that they need to have. The diagnosis of it being a medical problem and not necessarily a symbol of weakness or failure. Engagement of support systems happens organically back home. It is in short supply when we migrate out. So the result is that we are, as members of the community, first relying on ourselves and then probably on very few others compared to back home. Whatever support system is present, if the patient is comfortable with it, they should be engaged because they do provide support, they have understanding, and again, with explanation of the diagnosis and the care plan, they can help in alleviating a lot of the initial stress, the newness of the diagnosis and the treatment plan. As I've talked about, medication management requires certain sensitivities to be kept in mind. The value of psychotherapy needs to be emphasized as a valuable tool and which is available to them. And I'm sure most people who are clinicians on this call would be surprised to realize how receptive the population is. The destigmatization and normalizing the care I've already touched upon. So culturally competent and sensitive teams are significant part of effective psychiatric care for this population, for any population. However, recognition of their immigration history, recognition of their struggles, what they're dealing with now, language barriers, recognizing cultural norms. This is all something which comes through education and for clinical teams to be aware of them. This attitude towards the minority population, be they Asian Americans or any other, starts with our first contact with them. When they call the clinic to ask for help, all the way to specialist and subspecialist care, our attitude and approach of being receptive, respectful, inviting, can carry a significant amount of influence in how much the patient feels that they can have ownership over their care plan and investment into their treatment plan. Availability and support from the clinic is something which patients test out all the time. It is important for us to be able to show them that we are available, that we are supportive. And this all anchors around the basic principle of education, in which the more aware clinical teams are, the more aware patients are, the higher the likelihood of success. I think just for the sake of time, I'll just stop here and I look forward to any questions that folks might have for all of us.